Hi everyone. Today I'll be presenting on staphylococcal skin infections, focusing on folliculitis and boils or styes, impetigo, and scalded skin syndrome. This presentation will walk us through how each of these conditions develops, how it spreads, and how it is treated and prevented. Staphylococcus aureus naturally lives on the skin and inside the nose of many people. Most of the time it doesn't cause problems, but when it enters the skin, it can lead to infections that look like bumps or pimples. People with weakened immune systems or chronic health conditions are particularly at higher risk. As shown in the image here, you can see that the bacteria appears clustered and can easily colonize skin surfaces. Folliculitis and boils begin when S. aureus enters deeper layers of the skin. The bacteria releases virulence factors and toxins that damage tissue and help them evade immune system. Pore-forming toxins break down host cell membranes, while leukotoxins specifically destroy immune cells like neutrophils, which explains why pus forms, as you can see in the image here of a carbuncle, which is a cluster of boils. Folliculitis presents as tender red bumps around hair follicles. Boils are deeper, painful infections with a central pocket of pus. Styes form when an eyelash follicle or gland becomes infected. As you can see in each of these images, there's an example of each condition. As far as transmission is concerned, staph spreads easily through direct skin-to-skin contact, especially in contact sports. Sharing personal items like towels, razors, or gym equipment increases the risk. Staph can also spread through frequently touched surfaces and touching or picking at sores. Treatment depends on severity. Warm compresses help encourage drainage. Topical antibiotic lotions or gels work for small areas. Oral antibiotics may be needed for more serious or widespread infections. As far as prevention, it really comes down to hygiene. Regular hand washing after practices is essential. Keeping wounds covered with waterproof bandages and avoiding shared personal items also helps. You can see in the CDC hand washing poster here, it visually reinforces how important hand washing is. Now on to impetigo. It's the most common in young children, especially those with frequent minor skin injuries and close contact with others. It is also caused by S. aureus, but also can be caused by Streptococcus pyogenes or both. The bacteria enters small skin breaks and can spread easily. You can see in the image here, there's a classic depiction of the honey-colored crusts here, which forms around the mouth and the nose, which helps to identify impetigo. Impetigo develops when bacteria attach to the superficial epidermis or the outside of the skin surface. S. aureus releases exfoliative toxins that disrupt desmoglein 1, the protein that holds the skin cells together. And this leads to thin-walled blisters that rupture quickly. The histopathology image here on this slide demonstrates the toxin-related separation within the skin layers. Non-bullous impetigo is a type of impetigo which begins as small vesicles or pustules that rupture easily and leave behind erosions with the honey-colored crusts. Lesions may itch or be mildly painful. Bullous impetigo is another type of impetigo which you can see depicted in this image here. It involves larger fluid-filled blisters which are caused by the toxins. The incubation period is typically 2 to 10 days for impetigo. As far as transmission is concerned, impetigo spreads through direct contact with sores or nasal secretions. It is especially common in group settings like schools or daycares. It can also spread through contaminated items like towels or clothing. For treatment, gentle cleansing removes crusts and reduces bacteria. Warm compresses can soften the crusts and help topical medicines to penetrate deeper into the skin. Topical antibiotics may also be needed to treat mild or localized infections. And of course, oral antibiotics are used when the infection is widespread, resistant, or bullous. As far as prevention, good hygiene is essential. Children should stay home when they've completed 48 hours of antibiotic therapy or are no longer contagious. Avoiding shared items and regular cleaning of surfaces helps to reduce the spread as well. And this poster here, also from the CDC, emphasizes key moments when children should wash their hands. Now on to scalded skin syndrome. This is a condition that's caused by strains of S. aureus that produce exfoliative toxins A and B. It primarily affects infants and younger children. These toxins spread through the bloodstream and can cause widespread blistering. The clinical photo here shows a perfect example of the characteristic peeling and erythema that can happen with scalded skin syndrome, where you just see the epidermis of the skin coming off and red, irritated dermal layer underneath. As far as the pathogenesis, scalded skin syndrome is a localized infection. It produces toxins that enter the bloodstream, and these toxins target the desmoglein 1, leading to separation of skin layers. This results in widespread blistering and skin fragility. The skin resembles a burn, even though no heat is involved. A classic sign is also the Nikolsky sign, and this is when gentle pressure causes the skin to essentially just shear off. And you can kind of see this happening in the microscopic slide here. It shows the loss of cohesion between the skin cells. Early symptoms of this condition include fever, irritability, and rapidly spreading redness. Within 24 to 48 hours, the epidermis essentially just peels away from the in large sheets, as you can see in this photo, and also can be some crusting or scabbing up of that. Children are at high risk for dehydration when this happens, and secondary infections can happen as well. So prompt IV antibiotics and supportive care typically lead to excellent results. Transmission of this condition occurs through direct contact with individuals carrying the toxin-producing strains. Most importantly, the peeling skin itself is not contagious, the epidermis that's coming off. Um, but outbreaks may occur in nurseries or neonatal ICUs. And so you can see in this image, this is a perfect environment where this condition spreads. As far as treatment is concerned, hospitalization is often required for infants and babies. Supportive therapy can include IV fluids, wound care, and pain control. Systemic antibiotics can also eliminate the underlying S. aureus infection. Blisters should not be ruptured, and that's to help prevent secondary infection. And for prevention, it relies heavily on strict hand hygiene in these healthcare settings where the condition usually is transmitted. Earlier identification and isolation of cases is also critical. Equipment and surfaces must be thoroughly cleaned, and monitoring for staph colonization can help prevent outbreaks within these settings. And on this slide, I have a comparison of the three conditions. You can see in this table, folliculitis and boils, typically affect deeper hair follicles compared to impetigo, which is more superficial and affects the epidermis, but is actually more contagious than folliculitis or boils. Scalded skin syndrome affects the epidermis, but can be severe in infants. So I would say the severity of scalded skin syndrome is obviously higher than folliculitis, boils, or impetigo. And summing up prevention for these conditions, there are a lot of commonalities across the three diseases. I think consistent hand washing is the most effective prevention method. Also avoiding shared items, cleaning minor wounds, maintaining environmental hygiene, and reporting infections early. Those all help to reduce the spread. And in my next slides, you'll see the references for both the literature and images that I used in my presentation. And finally, I'd like to say thank you for listening to my presentation today on staphylococcal skin infections, and remember to wash your hands.